But I just want to thank you all for coming on a Tuesday evening. We'll try and get started as soon as we don't run over time. I'm Ben Moret, who's the Deputy Director of the Raviglione Institute for Infectious Diseases. I'm based out of Westgate in the Children's Hospital at University. Unfortunately, our Director is ill tonight, Tanya Sorrell, but we are very privileged that our guest made it. Professor Mario Raviglione, who's the head of the WHO TV program. He's here attending or being the delivery speaker at the TV conference that we held in Sydney for the first time. It was conducted in Bishop last time. And I think we'll give you the best overview that we're going to get about the global key situation, but there's specific focus on the Asia Pacific region, which is very important to all of us. Thank you, Mario. And he will speak for about an hour and we'll have time for
hopeless. Hopeless. Then 1 hour, but so thank you very much, Ben, for the invitation. Thanks to everyone here for coming. It's quite a privilege to present at this prestigious university. I'm particularly happy because my son was here 3-4 years ago for 6 months, for a semester in an exchange program. He was doing international relations. So when he learned that I was coming here, he says, "Oh my God, my school," and so on. So I said, "All right, good." So he's particularly happy. That's why I want some photos so I can send it to him. He will be very happy. So, all right. Having said that, so what I want to do, if let's see, here, is to do 3 things, if you like. One is to talk to you about the TB burden and the progress that has been achieved, especially in the era of the Millennium Development Goals. Okay, so I will speak about global health. I will speak about epidemiology, I will speak a bit of science, so it's going to be a mixture of different sciences, because that's how you have to face TB, right? You cannot just face it on a microbiological level, or on a medical level, or on a sociological level, so you have to really mix all different sciences. So I will tell you about Millennium Development Goals achievement in this era. I will explain a bit more what they are if you are not familiar with it. I will speak about the present challenges that we have, and the response that the member states of the World Health Organization, including your Ministry of Health, that was quite active last year when when they passed this resolution. I must say that Australia was one of the top 10 or so countries that was engaged in the preparation of the resolution. And then I will speak about the way forward and can we actually eliminate tuberculosis. So, burden. So we published every year at WHO this global tuberculosis report. This is the last one. Last year in October, we are going to publish the new one in October. The data in tuberculosis don't change dramatically year after year. This is not Ebola that comes and goes. It's not an influenza that comes and goes. This is something that has been with humanity for thousands, literally thousands of years. And people believe now, if you go to sort of phylogenetic studies, that perhaps the proto-mycobacterium tuberculosis that causes the disease was introduced in pre-humans, in hominids, some 2 or 3 million years ago. So you're talking about a disease that has found its way to live with humanity and a very, I would say, balanced equilibrium. I can use this term because it doesn't kill everyone. It kills a small minority of people. It affects a small minority of people. But you have to think that there are some 2 billion people, 1/3 of humanity, that is potentially infected with tuberculosis. If you do a test, tuberculin skin test, or now we have a blood test called IGRA, or interferon gamma release assay, you do this kind of test, you will find that probably 1/3 of humanity responds positively. It means they have been exposed. And it means that they have a latent infection that in 90+% of the cases will never reactivate to determine the actual disease, tuberculosis, but they're there. And if they get HIV infection, they are diabetics, they are smokers, they are alcohol users, malnourished, and so on. They take steroids and so on, that they will go on potentially and get the active disease. So that's why this disease is with humanity. Imagine 1/3 of humanity being a carrier, if I can use this term. And we don't really know exactly among those who are positive, they respond immunologically to the exposure to the antigens of Mycobacterium tuberculosis. We don't know how many of those actually will, and who of those will actually evolve towards tuberculosis. So we have a complicated disease here. Just to start by telling you, it's a top infectious disease killer. So now I work at WHO, so we have to follow international standards for classification of diseases. And what is happening there is that the international standards say that in the case of tuberculosis that comes out in patients with or people living with HIV, you classify it under AIDS. So the deaths will be counted under AIDS. And there are about 400,000 people that die every year because of tuberculosis while being HIV positive. But I claim, regardless of now international classification, that in fact they die of TB, they don't die of HIV or they don't die of AIDS. And so if you look at the latest estimate, which is this one, recently UNAIDS published the estimate for HIV, saying that there are 1.2 million deaths. They include 400,000 TB deaths. While in the case of TB, our estimate is in non-HIV positive, 1.1 million. So you just add your 400,000 here and you subtract it there and you see that in fact it kills almost double than HIV/AIDS. And people don't realize that. Now, code of disease or not, it kills 1.5 million people every year, which is 4,000 people every day. And you can compare it easily with other causes of infectious death, and you see what the story is. So it's very simple. Incidentally, I don't want to do that because it's politically incorrect and not good for a tragic disease like Ebola, but I had Ebola here. Someone asked me to put Ebola in another slide. I didn't put it now, but I had Ebola. And so you won't see it in this scale. So just to tell you, and this was repeated today during the conference, Professor Reichman from the United States was saying, is there any other disease that you would accept as killing 4,000 people per day without reacting? And that is unfortunately what has happened for many decades in tuberculosis. We just accept it as part of the society. You know, people die, you know, they are the derelicts, the poorest, you know, the drug users, the alcoholics, the prisoners, so who cares? That's the reality, in fact, of the situation, which is really something we have to react against in a way, right, as the scientific community. So global burden of tuberculosis, 9 million people every year get ill, meaning they get active tuberculosis. 1.5 million die, I already mentioned that, and you see how many are in women. Oftentimes, among the causes of maternal mortality, people don't include the fact that, in fact, tuberculosis is at increased risk during, especially during the postpartum period. So there is an issue there, right? And there are at least 80,000 children that die every year because of TB. I already mentioned that TB-HIV is a very important problem, especially in Africa. You have 1.1 million people out of the 9 that get disease every year that are HIV infected. And there are about 360,000 or so that are dying because of tuberculosis. And finally, and this is the big scare, the one that has attracted attention to tuberculosis in the past couple of decades, is what we call multi-drug resistant tuberculosis. So this is a type of bacillus that causes tuberculosis that is resistant to at least the 2 most important drugs that we use in the cocktail of 4 drugs, in the regimen of 4 drugs that we have to use for tuberculosis. Isoniazid and rifampicin, to be precise. So you have resistance to these 2 drugs, you call it MDR-TB. And once you have MDR-TB, you are in deep trouble because that is a disease you have to treat now with second-line drugs. They are far more toxic than the first-line drugs, far more expensive. The treatment is not lasting anymore 6 months. It will last 18 to 24 months, and you have a cure rate that is around 50%, and so on and so forth. So we have to do everything possible to avoid the creation of multi-drug resistant TB. And you have, as I say, you have nearly 500,000 people every year that have MDR-TB, of which, incidentally, we get reported some 130,000. So something like, whatever it is, 20% or so. It means that 80% don't get drug susceptibility testing. And so we don't know. They have tuberculosis. If you don't do drug susceptibility testing, you don't know what you're dealing with. And you treat with the normal regimen, you will just risk amplifying, you know, the drug resistance pattern of that particular person. Now, this is the map of the world. This is the incidence. We calculate in cases per 100,000 people, or per million if you want to use the million. But this is per 100,000. So what you see here is that in Southern Africa, in this part of Africa, you have at least 500 cases per 100,000. Ben comes from South Africa originally, and he knows very well that in his part of the world, in this part of Africa, you may reach 1,000 cases per 100,000. I mean, 1% of the Southern African population gets tuberculosis every year, which is enormous. Consider Australia's 5.6 per 100,000, or say 5, to make it simple, per 100,000. Here we are talking 1,000. And then you have the rest of the developing world, so-called developing world. I claim that every country is developing all the time, but this is the so-called low-income countries, and you see in Southeast Asia, you have Papua New Guinea, for instance, and Myanmar, etc., that are really, they have a really difficult situation. Once you put these rates per capita into absolute numbers, then you find this kind of distribution. It means that while Africa has the highest rates per capita in the world, Asia, with the much larger populations, although the rates are slightly lower than Africa, so not 1,000 or 700, but is 200 or 300 or so, then you have this kind of pie. So 20 or 29% are in Africa, but Southeast Asia and Western Pacific together is more than half of the cases. And in fact, if you add a bit of Asia that is part of the Eastern Mediterranean region, like Pakistan or Afghanistan, then you are dealing with nearly 60% of the cases of the world being in Asia. The rest is, as you see, in Europe, in the Americas, and as I said, in the Middle East. Having said about the burden, now let me talk about the challenges. These are the 5 challenges I'd like to sort of simplify, the 5 challenges we have. So I mentioned that we have 9 million estimated cases every year, but in reality, the countries are reporting to WHO 6 million cases, officially reported. So there are 3 million that are estimated to exist, but not in the system. Do they exist? Well, anytime you do a special study, a survey, you find them. So I can assure you that it's around 9 million, the real incidence is not 6 million, which is what gets reported. So there are these 3 millions not in the system. In Southeast Asia, Indonesia, India, we know very well they're hiding, so to speak, in the private sector. So private physicians simply do not report. Simple as that. So you have no information, you don't know what's happening to them. And in other parts of the world, perhaps in rural Africa, you can imagine in rural Papua New Guinea, in places where the health system is very weak, then people don't have access to the clinics, they don't have access to health, and as a result of that, they may die at home because of HIV/AIDS. If you are in Africa, so always dying because of AIDS. In reality, this particular person would have a perfectly curable disease that is TB. Even in HIV/AIDS, you can cure TB at 90% level if you really treat the person on time. Second big problem is MDR-TB, and we call it a crisis. We have named it a crisis in WHO terminology, in a way, to call attention to this issue. I will show you some other slide on that. We have the problem of the response to the TB-HIV association. For those who are not in the field, HIV, of course, by demolishing the immune system and the CD4 cells, which are the lymphocytes that control several diseases, fungal diseases and so on, and tuberculosis, then exposes the person to a very high risk of reactivation from that pool of infected people. Then they can reactivate and get the disease. So their risk is about 30 or so times, 35, 40 times higher than a person that is not HIV infected once they get infected with tuberculosis or exposed to tuberculosis. So big problem in Africa, 80% of the cases are in fact in Africa. Increased financing is another big challenge. We don't have enough money for tuberculosis control. I will show you a graph. And the issue of research. So what we have available today in terms of diagnosis, treatment, vaccines is simply not sufficient to be able to say we will eliminate TB with confidence, right? We have many research gaps starting from very basic science. We don't fully understand immunology. We don't fully understand pathogenesis. It's a complex disease. We don't have in the pipeline diagnostics, drugs, and vaccines in sufficient number to guarantee that 10 years from now or 20 years from now we'll have really something that changes the way we take care of TB. And the operational research part is also not fully, I would say, not fully exploited. With operational research, field research, implementation research, you could solve many problems at very little cost. But that's not, for instance, the Global Fund, that is the biggest donor for tuberculosis internationally, is not devoting much resources to really the issue of operational research, which is programmatic research. You go into a district and you find that, I don't know what, the laboratory is not getting enough sputa. This was done by Tony Harris in Malawi years ago. You have a very simple solution. You provide them with whatever it is, a transportation, and then you solve the problem. So this is called operational research. Sometimes it's very simple research that costs almost nothing, but solves big programmatic issues. Now, in brief, these various challenges, just to illustrate better, this is the story of the missed cases. I already mentioned it. So 9 million is what we estimate, and 6 million is what gets reported. You see the trend in the past 20 years. And you see the countries here that are the responsible ones for the missing cases. And you see India, for instance, is by itself 1 million cases, not estimated to be there and not reported. I assure you, you do a survey in a slum with a doctor, you find the cases. They're simply hiding. They're not reported. And that is not good because you don't know in public health terms, this is now the science of public health, what that means, right? If you don't know the case, if you don't know if the case is treated well, if it's cured, etc., you have no idea of what the program or the curative type of program is doing. Second big problems, I mentioned MDR-TB. So these are percentages. It means you have a new case, never treated before, because if they have been treated before, then you will have a higher, much higher chance of having or dealing with a multi-drug resistant case, because it would have been mistreated, and one mistreatment after another produces multi-drug resistance in the end, right? So here is new cases. So these are cases you see for the first time. So how much in percentage term, how many of them are multi-drug resistant? So you see where the problem is in the former Soviet countries, because of a number of reasons which we can discuss later on. But there you have situation of above 30%, 1/3 of the cases, new cases of TB that appear for the first time to the, in the clinic and so on, and are diagnosed with tuberculosis. They have multi-drug resistant TB. So you make the mistake of not doing a susceptibility testing and treating the case as if it were normal TB. You are just simply not only not curing the person, but you are potentially producing additional resistance to perhaps the fourth drug or the third drug to which the patient is not resistant. However, in absolute terms, China, for instance, has 5.7% drug resistance in national surveys that have been done very, I would say, very effectively. They have just, so to speak, 5.7%. But once you translate that into a number of cases, that 5.7% out of roughly 1 million cases a year means about 60,000 cases. So you have the largest number in India, China, Russia, Pakistan, Ukraine. They are responsible for 60% of the global burden of multi-drug resistant TB. And if they don't respond, like China, for instance, that is not responding to the MDR-TB crisis, they just put on treatment 5,000 patients per year out of about 50 to 60,000, so 1/10. India is responding more quickly now. They have about 20 or 25,000 out of another 60,000 or so estimated. So if you don't do drug susceptibility testing because you don't have the laboratory, or you simply don't think about it, and so on, then you are not reporting MDR-TB, you don't know, and you're treated with wrong drugs. And you're not only killing the patient, but also producing additional resistance that then spreads in the community. So it's a big problem. TB-HIV means really Africa. Let's see if 78%, I already mentioned, nearly 80% of the cases are in this continent. And in some, these are zero prevalence, so it means you expose the TB person to a test for HIV, you will find in this part of the world that over 50% are HIV positive. There are famous stories there in Malawi, in some cities or so, where 80% are HIV positive. So having a diagnosis of TB means almost surely having had HIV for a while. And then there is the issue of other comorbidities that are now emerging in other regions. For instance, the diabetes TB co-epidemic. Diabetes is another factor of risk. So if you are infected with tuberculosis in a dormant way and you have diabetes, you are exposed to the risk of reactivating the actual disease. And this is, for instance, in Mexico, in this type of population, is quite a common interaction. Another big challenge I mentioned is that of the funding, and this gives you an idea. So now this is an estimate of some $8 billion necessary every year to to deal with TB, to control TB. It's based on an estimate that we make, knowing the expenditure that countries put into that. In TB, contrary to HIV or malaria, I must say that the majority of the funding comes from domestic resources, because TB, contrary to HIV and malaria, is not a disease of Africa, it's a disease of the BRICS and of the middle-income countries that have enough money to put their own domestic resources, which is good for sustainability, okay? But it doesn't solve entirely the problem, because still, with those domestic resources and a bit of external international funding, you have still a gap of about, estimated to be about $2 billion per year. And in the case of research, the gap is even higher. The investments in research have just resumed maybe 15 years ago, after a good 20 or 30 years of very little research in TB, because people thought they had all the tools. We had the diagnosis via the microscope, we had the culture capacity, which lasts 2 months. We had the treatment, the treatment dates back, the same treatment we are using now dates back to the 1970s. We had even a vaccine called BCG, that, as probably you all know, doesn't really work well. And so people interrupted the research efforts. It was resumed in the early 2000s. I think largely it was pushed by several agencies, including the Rockefeller Foundation that created the TB Alliance, the Gates Foundation particularly that came in with a large amount of money for TB research. To the point that now of this, if you look at the amount available now for research per year is in the range of 677 million. Half of it comes from the United States, NIH, National Institute of Health, and the Gates Foundation. The rest is coming from other smaller sources around the world, UK, Wellcome Trust, MRCs, and so on. But it's relatively small part, and many OECD countries, so countries that are part of the cooperation for development, are not really investing at all on research for tuberculosis, having forgotten that this is a disease that still, as I say, kills many people. The other final challenge is that of research. So, first of all, is fundamental for the new strategy. I will show you this graph later on. I will describe it in more detail. Secondly, the investment have gone rather flat in the past few years. I mentioned already that, in fact, in the 1990s, you would have had not even half of this available for research. Then it grew in the early 2000s, thanks to the Gates Foundation and the NIH, particularly in the United States. It kept growing, and then it got flat after 2009. So we are roughly at the same level. So which is not a good sign. It means there are no new investors in research. And without a new investment in research, then it's very difficult to find solutions. That's the point here. And just think that NIH, that is the largest with the Gates Foundation investor, which is about 150 million per year that they place on TB research, invests 20 times more in research for HIV/AIDS. When the two diseases are comparable, in fact, I claim that TB kills more. So that's what the reality is in the world. And finally, the needs in research are very clear. This is what everyone wants. The understanding better, I mentioned already, pathogenesis and immunity, having rapid, sensitive, point-of-care diagnostic tests, so you don't have to depend on sophisticated laboratory technology. You can do it at the point of care, and that will allow us to screen for tuberculosis in a much more effective way. Having shorter regimens than the 6 months that is required, let alone the 18 months for multi-drug resistant TB, and for latent TB infection. We can use prophylaxis. The problem is it's a bit toxic, not too much, but it's lasting 6 months. And if I tell you that 1/3 of the people inside here are probably carrier of tuberculosis, and I say you have to now start taking isoniazid daily for 6 months minimum, then I don't know how many will finish 1 week. That's the issue here with chemoprophylaxis. So it's not an easy thing for people who are perfectly healthy and feel healthy, and in fact they are infected. Then we need an effective vaccine. That's probably the final solution to tuberculosis, but I think we are far from that because we don't understand the pathogenesis and immunity well. And finally, we need a lot of epidemiological health system and implementation research, which is what I need. But the needs have been clear. There are books there. You see some of these reports. These are the various pipelines of development of diagnostic drugs, vaccines. there is an international roadmap for TB research that defines what needs to be done, really. So it's a matter of investing. So all of this, in a way, is the summary of this era, the era of the Millennium Development Goals that ends in 2015. So the United Nations back in 2000 defined that it was time to set some important Millennium Goals. They were a blueprint agreed upon by all countries that signed off with the Secretary General of the United Nations to develop further, to allow the development further of the world, right? Galvanized certainly unprecedented efforts, and there were major initiatives that were launched in this era, including, for instance, for what concerns tuberculosis, the Global Fund. The Global Fund against HIV, TB, malaria is the major financing institution. Your government, the Australian government, places in these 3 years, 2014, 15, 16, $200 million, for instance, for the Global Fund. And 3 out of the 8 MDGs were focusing on health. And these are the MDGs, for those who are not familiar. So you see that the number 1 is the obvious one, eradicate extreme poverty and hunger. But then you have MDG 4, reduce child mortality, MDG 5, improve maternal mortality, and MDG 6, combat HIV/AIDS, malaria, and other diseases that were devoted entirely to health. This was, in a way, a major recognition that health is an important factor, is a fundamental factor for development. And if you look at MDG 6, for whatever reason, they didn't name tuberculosis, which is a scandal that I never really understood. But if you look at the indicators under this MDG 6, you will find that the indicators are for HIV, for malaria, and for TB. Why, instead of calling it TB, they called it other diseases? It's really a mystery. I don't know. I mean, I heard several stories, and my ex-colleague Richard was also probably a part of those discussions 15 years ago when he was in Wipro at very high levels, so he might add some information on that. But I was really surprised, and we even tried with the resolutions at the World Health Assembly in 2005 to revert that. And because there was a chance in 2005 to rename some of these, they rejected everything. But there was a resolution at WHO that said, just put tuberculosis there as well. So we can actually say there is tuberculosis as a problem. So that is what happened. And overall in this era, that is what the result is. This is the latest report of the United Nations on the status of the Millennium Development Goals, published a month or so ago, in August, I think it was. And this is the page on tuberculosis. So recognizing that through effective prevention, diagnosis, and treatment, the burden of TB has decreased. And what has happened there is that there was a slow increase in the 1990s, very fast in Africa, very fast in the former Soviet Union, but then after that, overall in the world was like that, but then after that, a peak was reached around the mid-2000s, say 10 years ago, and after that we are seeing now a very slow decline in the annual incidence. A bit faster was the decline in mortality, because as long as you put together some type of treatment, whether it is not ideal is another story, then you can prevent mortality. But you may develop drug resistance if you don't do the right thing. So overall, 37 million lives have been saved between 2000 and last year or so. This year we published the new, an estimate will be 41 or so million. And the other indicator that has been used is that of treatment success, meaning cure rate. How many people are we curing? So we know pretty much what is happening with the 6 million people that are reported. We don't know about the 3 million that are not reported. But among those that are reported, you have this kind of trend. Sorry, let me just go back. We have this kind of trend. So ignore the rich countries that have pretty low cure rate, but because people disappear from the system or they're not reported, not because they don't cure people. But in low-income countries, you have this kind of trend, which has stabilized around 85 or 87%. We used to have a target, and we still have it, of at least 85% should be cured, and that is being exceeded now for the last few years. These are more of the same statistics in our report, so I'm not repeating that, but I'm coming now to what is happening, therefore. So this is a very simple, it's not a model, it's a very simple graph to illustrate the situation. So here we have the current rate of decline, which is 1.5%. There's been a target set for 2050 of elimination. It means less than 1 case per million. This is 0.1 per 100,000. 1 case per million. That is the definition in TB of elimination. So in order to achieve that, we should go down, as you see, at 20% per year. And we're going down at 1.5% per year. So we are far away, right? What has been the best experience in non-rich countries, call it this way, or non-OECD countries, is that of China and Cambodia. With prevalence surveys, we know that they are coming down at 4% per year. The best experience ever is that of Western Europe, especially the Netherlands, that had very good system of monitoring, when during the 1950s and 60s, they managed to come down at around 10% per year, half a century ago, when they introduced diagnosis, treatment, as it has to be, and social protection, and what we call today universal health coverage, because everyone, in my own country, I come from Italy, so if you had tuberculosis, then you could go to the system, no one will charge you for diagnosis, no one will charge you for treatment, you will have social protection mechanism that allows you to get reimbursed, so to speak, of the loss of income over a period of 6 months' time, right? So with that type of interventions, and of course the economic growth, this was post-war and so on, then you had this minus 10% per year, that then slowed down later on. That is important because on that basis we are now assuming that we can eliminate TB or we can end the epidemic. So now we are entering a new era. The 2016-2030 is going to be a new era of what we call the sustainable development type of approach. So new ambitions and a paradigm shift. World leaders agreed at the UN General Assembly a year ago, and this will now be ratified at the new General Assembly in 3 weeks' time. So hopefully nothing will change because it's important for TB because we are there now. And they agreed that we should go beyond the Millennium Development Goals and should set another set of targets that go to 2030, another 15 years. And they've defined sustainable development in the way you see. Is the one that promotes, and we can go a long way here, but freedom, peace, security, respect for human rights, adequate standards of living, food and water, rule of law, good governance, gender equality, and so on. We have to build, therefore, a new strategy now in this new era that fits with this type of philosophy. They emphasize the importance of international cooperations. We are in the famous global village, so we cannot really reason as if Australia is isolated, so who cares, right? We cannot just do that. And in fact, Australia is a very good example because 90% of your cases, this must be the censorship. 90% of your cases are among the foreign-born, right? So that tells you that you can't control tuberculosis just limiting whatever you can limit. It's a disease that travels regardless of borders, unfortunately. And then sustainable development goals have been therefore proposed. What are they? There are now 17. With some, I can't remember now the number of targets, 150-something targets. So it's much broader than the previous framework of 8 Millennium Development Goals with 3 on health. Now we have 17 of them, and one of them is on health. It's called Ensure, long debates about this, but ensure healthy lives and promote well-being for all at all ages. And importantly, under this, there are now 13 targets. So if you remember, goal 6 had HIV, malaria, and then TB as indicators. Now here we have a number of indicators, obviously, and targets. And the one which is important for tuberculosis is this one in 3.3, which talks about not anymore halting or combating the previous language or stopping. Now we are talking about ending the epidemics of HIV or AIDS, tuberculosis, and malaria, which gives us quite a powerful advocacy tool in a way, right? Because we are saying we are going down, although slowly, but we can now end the thing. And this is what WHO is doing now, is WHO is in charge among the UN agencies to put together the indicators for, and the targets in a way, for all of these various 13 health groups of targets, and you see that TB incidence and number of deaths are there, which is very important, and they coincide, as you will see, with the NTB strategy concept. So the important part here is to have ensured that tuberculosis is visible in a way in this framework, because you may just think, well, this is just UN language. In reality, this is what influences the donors, the countries, the governments in doing things. If you don't have tuberculosis there, you don't exist, put it that way. So that means also this new philosophy changing, in a way, the paradigm. So I'm trying to summarize what the paradigm of health in general is and adapting it to tuberculosis. So from halting here epidemics, we are talking now about ending. I already mentioned that. The other crucial point is that the point of putting the patient at the center. All people are at the center, they are vulnerable, and they have to be treated like that. There is a translation of the quest for equity and social justice and universal coverage, social protection into access to, in practical terms, high-quality services that allow, in our case, the diagnosis of the disease, the treatment, and so on, without having patients incurring catastrophic expenditure. That's why we have placed catastrophic expenditure as an important indicator, together with incidence and deaths, as you will see in a few minutes. So it means, in other words, that you cannot afford to deal with a public health problem, with a public health good, by charging patients and thinking that by charging the poorest among the poor, you will ever control a disease like this, because they will simply disappear from treatment. They just don't have money, they become poorer and poorer, and they don't complete treatment. And that is not just for the individual, that becomes a societal issue. Rapid introduction of innovation is another part of this new framework. Rapid introduction, it means not just in Australia or in the United States or in Western Europe, but it means where the tools are needed. And we are moving from a all-of-government approach that was more or less the mentality of the MDGs. So we just need not just the Ministry of Health, but also other ministries. Now we are talking about all-of-society approach. And we have, in a way, to face diseases like tuberculosis or any other in the same way I could say that that was the case for HIV/AIDS. That was really a sort of all-of-society approach. It was not just the mobilization of the ministries of health, as we well know. So the same concept would apply with the same mobilization and so on to other conditions like our condition on tuberculosis. In the end, for us, it means targeting acceleration of the decline of incidence and mortality that I've showed you in the previous slides. So to respond to all of this, the World Health Assembly, Ministers of Health of the whole world, last year in May, passed this resolution. At the time, we did not have a name for the strategy. Now, we are calling it the End TB Strategy. And there are, if you are interested, I just am left with one now, but these are infographics that describe what I'm going to describe now in the next few slides. There are even some pins here, if you are fanatic about pins that we are making on the End TB Strategy. So we're using it to promote the concept, to sort of brand it in such a way that it's easier then to remember what we are talking about. Now, global TB strategies have evolved over the past 20 years. The first one that probably many know is the so-called DOTS strategy. That was the basic, and it was really the necessary one in an era of therapeutic anarchy, as it was called, where there was anarchy, there was no standard. So DOTS strategy in 1994, launched by the World Health Organization at the time, defined what the essential elements of TB control are. So diagnosis through a certain approach, treatment standardized with the 4 drugs I was mentioning for 6 months, system of regular supply of drugs, establishment of a monitoring system that allows us to measure what we are measuring. We had to evolve it. In 2006, we decided it was time to evolve it into what we call the Stop TB strategy, to respond in a way to the challenges of the Millennium Development Goal era. And that meant maintaining, of course, the basics. That's why we say, number one, pursue the high-quality DOTS and so on, but then facing the new challenges, like TB associated with HIV, like multi-drug-resistant TB, like building the system within the existing health system rather than going vertically, as it was in previous eras to TB control. Now we really need to build it as part of the building of health services, because if we don't have services, people with cough don't go anywhere, right? So you must have primary care in place. To make it simple, engaging all care providers. Think about India and Indonesia, what I told you. Without the engagement of the private sector, you cannot, and this is valid for any other condition that has a public health significance. Without that, you don't really have an effective system of controlling any disease or any condition. And empowering people with TB, putting them at the center in a way, and research. That evolved further into the new strategy that is now sort of synthesized in 3 pillars, and I'm going to talk about them. So, before talking about them, just to give you an idea of what the various eras in the last 20 years were, you have the anarchy era, then there was the introduction of the DOT strategy at a time when the incidence was growing. This is a magnification of what was happening, was coming down, and it grew dramatically in the 90s to reach a peak and then come down. It's only between 150 and 152 rates. So it's a magnification just to show in an exaggerated way what was happening. Then we were able, in other words, with that approach to sort of start reverting the epidemic. Then we entered into another era of the expansion of the dot strategy that was being put everywhere. I must really remember, Richard again is here, I must remember the big effort of the Western Pacific region that was by far the best model in the world. In this region, what was done during that era of the let's say the 2000, was a major push to countries to really adopt this strategy and do it in a right way. And that's why the Western Pacific region is coming down fairly nicely. You have countries like China and Cambodia that are coming down at 4%. Not all of them, unfortunately. And then there was economic growth, there was new money coming in, the global fund, etc. And now we are in a new era where we have to really accelerate this decline that has been achieved already, and that acceleration has to go this way if we want to achieve our target. So we have to use all the tools we have in the best possible way, making sure that this universal coverage concept and this social protection concept are put in place, and keep pushing governments to do it, and rely on the economic growth of countries. If you look at the World Bank projections, you will see that many low-income countries now of Africa and Asia will become middle-income countries as defined nowadays in 2020. So that means that there will be economic development that is another big factor in pushing the incidence of TB down. We have set very ambitious targets in this resolution. The countries have set very ambitious targets, and I just put them in the context. These are every 5-year milestones. This is the Sustainable Development Goals, and coincides with what is being proposed in the framework there of the Sustainable Development Goals. 90% decline in mortality, 80% decline in incidence, and zero catastrophic expenditure to patient, which means that we will now start a serious measurement of this parameter here, this families facing catastrophic expenditure. It's easy to say we have universal health coverage, then you measure and you find that patients with TB that are the poorest among the poor become poorer. And so that means you don't have universal health coverage in simple terms. So we are going to try to measure that with the final end TB strategy ending in 2035 with these other type of targets. Strategy is based on 4 principles that are aligned with the SDG philosophy: government stewardship and accountability, building strong coalition with civil society, communities, the non-state sector, protecting and promoting human rights, ethics, and equity, and adaptation of the strategy, which is actually what's happening in this region. That's all we are talking about in this Congress, the adaptation to the Western Pacific region, to the Asia-Pacific region as they define it also, which is different from what is happening in Africa or in Latin America. And the NTB strategy is based on these 3 pillars, you see, pillar 1, 2, and 3. Pillar 1 talks about integrated patient care, is the old DOTS strategy that has been expanded now, including all the innovations. So that is early, not just diagnosis, but early diagnosis, because that's how you cut the transmission. Once you diagnose, you can treat. Within 2 weeks, a person is not infectious anymore. Early diagnosis using, by the way, rapid tests that are now available, and they're not yet used as they should. Universal susceptibility testing, so you understand immediately if you are dealing with a multi-drug resistant case. And then treatment of all people, the necessary TB, HIV interventions that are a bit more than the usual, and preventive treatment for those persons with latent infection, I was referring to, that have a very particular risk, and they are particularly vulnerable. And then the second pillar, which is the fundamental one, is probably the real innovation here, is to really push for, I would say, point C and D, particularly policies that ensure universal coverage, and they ensure social protection and the inclusion of tuberculosis in the socially protected individuals. Social protection has been, for instance, in the case of Brazil, a very strong element. And when we raised the issue that we need to understand better social protection in TB, we were invited by the Brazilian governments to go there and hold a global meeting, which we did, a workshop to try to understand better. And surprise, surprise, you find out that even in Brazil, where they have a lot of social protection awareness, people with TB were not necessarily talking to the people in this Ministry of Social Welfare that was dealing with social protection mechanisms. And as a result, there were several of these mechanisms. The most famous one is called Bolsa Familia, which is an incentive given to people if they vaccinate their kids, they get a certain amount of money. In the past, it used to be food and so on, but they did not include tuberculosis patients. So that's a paradox, right? Because these are the poorest among the poor. So this is what needs to be corrected by those who deal with tuberculosis. It's a matter of changing a bit the mentality and thinking beyond just the care of the people and the diagnosis and the treatment, which remain fundamental. But you have to have policies in place. And finally, research. And I don't need to repeat the concept of why we need research. This is the curve I was referring to before. We are going down at 1.5% per year. By the optimization of what we have now and ensuring there are these universal coverage policies in place, we can get down at the maximum at 10% per year. This is a little model. We will publish soon, actually, the targets, setting, the process of doing this. We have to go down at 10% per year. That's the only way that we can, in a way, reach these famous targets I was talking about. But then after 2025, we have 10 years to reach that level. Right? After that, we will have really, we will need really new tools. We chose the 17% per year here because that is the maximum ever achieved in a human population. It was not a country. The country is the Netherlands here, the 10%. This is the experience of the Americans in Alaska and the Canadians in the Northwestern Territory in the Inuit or Eskimo populations. That's what they achieved half a century ago, putting in place everything they had, not just the basics like dots, but also preventive therapy, for instance. Also early screening. Now we have a bit better tools than half a century ago. So the hope is that with further improved tools like those I mentioned already, we can get there. Now, I would say that to end the epidemic, what we need, I don't know why the title disappeared. All countries, especially the BRICS, have to optimize the use of current tools and strategy and rapidly introduce those that are emerging from the pipeline that has been revitalized in the past 15 years. Investment in research for new tool has to rapidly increase, and I mentioned already what we need. First of all, I said it, universal health coverage and social protection for the poorest. Without this mechanism in place in the broad health system, type of strengthening approach that you must have in any society, it will be very tough. I mentioned that already. And just see the results of a systematic review that we did on the cost to a family, a household, when you have tuberculosis. So on the left, you have the cost before treatment, and you see that medical expenditures are about 17%, other type of expense like transportation is about, 8%, and the lost income is about 26% prior to diagnosis, because people go on for weeks sometimes in trying to understand if they have TB or something else. And then during the treatment, here, the 50% of the total cost are during the treatment, and you see how they are distributed. And in conclusion here, the loss of income is responsible for the majority of the cost to a household when a person has tuberculosis. And you can address those things by universal health coverage, which means not impoverishing people with diagnosis and treatment. That is the blue part that you're addressing, and with social protection mechanisms that can take care of additional expenditure, whether it is nutrition or transport, and particularly the loss of income. So we really need to think this way if we want to stop this, and we want to really push down further this epidemic. Here is some statements. It's a disease of accommodation, right? We all know that with the poor logistic and the poor housing and so on, you have a problem when it comes to diseases transmissible like tuberculosis. And the state can easily remedy the situation with suitable laws. That's I think, these are important principles. Now, talking about universal health coverage, the definition, just to make sure that we understand each other, that was in one of the WHO reports in 2010, means simply universal access to the needed health services without financial hardship in paying for them. In our case, it means you have to basically provide, if not free diagnosis and treatment because the system is not the same, insurance that allows you to pay for the diagnosis and treatment. That is what is really important. And then I don't go into other details, but Obviously, if you're thinking MDR-TB, the cost of drugs for tuberculosis 6 months is in the range of, say, 40 to, I don't know what, 50 Australian dollars for 6 months. When you have MDR-TB, you're talking about 100 times more, depending on the countries where you are. You're talking $3,000, I'm talking American dollars now, $3,000 to $10,000 just for the drugs, let alone the loss of income, let alone the monitoring visits, the hospitalizations, the blood drawing because people have side effects, and so on. So really, there is no one. If I had MDR-TB, probably within a matter of 1 month, I may become poorer than I am, you know, and I have a good salary at WHO in a way, right? So imagine someone that doesn't have a good salary at WHO and lives on, I don't know what, $10 per day, is killed in 1 week. That's what it is. Now, talking elimination, there has been this model, I always use it because it's a good example, it's a good model, that shows what needs to be done to try to eliminate TB. Top left is diagnostics. And there are different options there. The best one is to have what we don't have today, a dipstick point-of-care test. It's like what you have in HIV. You have this, you know, the salivary test. You go to the clinic, you have someone coughing, puff, puff, positive, negative, and there you screen people effectively. We simply don't have that. Even if we had it, though, the incidence of tuberculosis will not get to this point in 2050, which is the elimination point. We'll just stay about there. It will, you know, reduce by half the burden, but not enough. What we need instead is either a drug or a vaccine. So in the case of the drug, you have different choices, different options in this particular model, but just concentrating on the pink one, what you have there, the pink one, is an active disease regimen 2, defined as a 2-month, not 6, but 2-month, effective also in multi-drug resistant TB. It means a completely new regimen, associated with mass latent therapy, meaning therapy prophylaxis for those who are latently infected. If you had this association, then we could have the ambition of eliminating TB in 2050. We don't have that. We don't have a 2-month regimen, and we may have now a shorter regimen for chemoprophylaxis. It's just the latest, what we are now recommending basically is 12 weeks of once weekly isoniazid and rifampicin. So with that regimen, which is only 3 months, it's only once a week, we can have more massive latent infection treatment. And finally, vaccine. And in vaccine, as I said, I think we are far away, but a pre- and post-exposure to the TB bacilli, right? Pre- and post-exposure vaccine, that would be 90% or so effective, then we could achieve elimination of TB. So to eliminate, a quick point-of-care test for disease and for infection, very short potent regimens, simple regimen for chemoprophylaxis, or a vaccine. And the synergy of interventions is what counts, and you have to act, and these I'm getting a bit more now into the nitty-gritty, but both transmission and reactivation pathways. Transmission pathways is what prevents, in a way, the first infection. It means diagnosing immediately the case, and the reactivation pathways is once you are infected, you are HIV positive, malnourished, etc., you reactivate it. We have to act on both synergistically. There are other models that show that. Now, what is emerging from the pipelines? These are the latest pipelines for diagnostics, for treatment, and for vaccines. And you see what has been happening. We have several new diagnostics that WHO has endorsed for use in all countries, including the most revolutionary ones that are the expert machine that allows you to really have a diagnosis of TB and of multi-drug resistant, in fact, of rifampicin resistant, which is a sort of proxy for multi-drug resistant within 2 hours. Or the line probe assays, which is another methodology, a bit more complex, it takes a day or 2, but they are the same, they have the same efficacy. By 2020, the aspiration is, or the ambition is to have a rapid and sensitive point-of-care test. There are some that are under evaluation, and probably in the next couple of years, we'll know more about that. The final aim, once again, is to have a point-of-care test. In terms of drugs and regimens, for the first time in half a century, we had 2 new drugs fully developed for tuberculosis, bedaquiline and delamanid, that were approved by the US FDA or the European Medicine Agency, EMA, in the past couple of years, that we have, as WHO, endorsed for use, but they are limited to multi-drug resistant TB at the moment. They have been studied only for multi-drug resistant tuberculosis. And what we want is a much shorter regimen, both for treatment and for infection. Some results will become available in 2018 of current trials that are trying to, for instance, shorten the regimens to 4 months for TB or 6 months for multi-drug resistant TB. And we'll know if they work in a couple of years' time, in 2-3 years' time. Finally, vaccine. Unfortunately, here we are a bit late in the pipeline, and there was one that had been studied, was reported, I will show it later, was reported 3-4 years ago in South Africa, as a matter of fact, and failed. And so that was actually hitting very much in a way, the enthusiasm that was there for the vaccine development. This is what I was referring to. For instance, this is the expert machine that literally in 2 hours can give you the result. You put the sputum in. It's a very simple process. Is a PCR amplification technique, I should say, and it has been actually growing in terms of distribution, in terms of purchasing of this particular machine. This is the pipeline for new TB drugs in more detail. The 2 drugs that have been approved recently are bedaquiline, as you see there, and the other one is delamanid, which is this one, developed by the Otsuka company in Japan, while this was developed by Johnson & Johnson. And these 2 drugs are used for MDR-TB. There are important drugs here, and especially this regimen, which is bedaquiline. Pretomanid is an analog of delamanid, is a nitroimidase, also is a completely new class, and pyrazinamide, an old antibiotic, an old anti-TB drug, sorry, not an antibiotic. And these 3 together have been combined now because of mouse studies showing quite promising results, and are being tested, and this is what I was alluding to. It was studied as a sort of universal regimen because you would have very little resistance to any of these. The drugs now is not exactly like that, because we found out that there is much more resistance to, for instance, pyrazinamide than we all thought. So it's a problem. This is what we have done in WHO, for instance, on these drugs. We have not only now a policy implementation package for new drugs introduction that tells you how you should or you should not introduce the drug, with the risk of then developing a resistance, and then how to use bedaquiline or how to use delamanid in the treatment regimens that exist today for multi-drug resistant TB. This is the challenge of multi-drug resistant TB. I alluded to it a bit, but just to tell you, there are 136,000 cases notified, and there are 97,000 last year that were placed on treatment, meaning 40,000 were not. And that is a major problem because it's an ethical issue now. You have the diagnosis, because there has been more rapid intake of rapid diagnostics, but not enough drugs or not enough systems in place to allow the drugs to be used. And not only, but then there is a cure rate of 48%. So that's a real, in a way, it's a real challenge, this one. Finally, the vaccine pipeline. There are several, about 15 or so vaccines that are being tested. They are still in a relatively early phase 1 or phase 2A in the clinical trial pipeline. And this is the one that failed in South Africa, was reported in The Lancet back in 2013, 2.5 years ago. Unfortunately, it didn't work. And what the conclusion was that it was feasible to test vaccine candidates. But unfortunately, it didn't work. So, and this actually hit pretty much the efforts on vaccine, and our colleagues that work on vaccine had to really find right arguments to continue being financed and funded when you have a situation like this. Funding for research I mentioned, flat line, and why is it needed? What research is needed? What I want to say here is that there was an article we published in The Lancet a couple of years ago where we claim that the research capacity has to be built now, especially in the BRICS or in middle-income countries, because that's where the problem is and that's where the growing economies are. And so there must be increased commitment by everyone, including Australia, for instance, but by all OECD countries, but also by these BRICS. That's what the argument was. So the conclusion of this is essentially that strategic financing is fundamental now to ensure that all countries can progress towards ending the TB epidemic. And it means that we need continued international financing, especially for the low-income countries. We need the BRICS and other middle income like Indonesia that is not part of the BRICS to really take responsibility and do more in terms of not only their own domestic but also a global control. We need to boost research, especially in the BRICS. And we need the support of OECD countries with their bilaterals, including Australia, the Global Fund, and other international agencies, to coordinate in such a way that the help goes where it is needed, meaning in the low and the low-middle income countries, while leveraging domestic resources, more investment by the BRICS themselves. So the domestic investment is obviously essential here to ensure sustainability. And second part, collective leadership to end the epidemic is necessary. So country-owned TB plans for operations and research must be there to ensure that we have sustained long-term efforts. Implementation of the new TB strategy that we just described is now everywhere. Theoretically, it should start on 1st January 2016. There are several countries that are already implementing it, and they have plans to implement all the elements. Of course, they're struggling with some of the innovations, like how to deal with social protection. When you are in the Minister of Health in a poor, so to speak, national TB program, how do I deal with the Minister of Social Welfare? That's a real challenge. And it has to be solved at the country level. It's not an easy answer or generic answer. Partners and donors need to coordinate in such a way that we can synergize all the efforts in the implementation of programs and in research. The civil society voice is obviously crucial. And the Australian government, we keep repeating that in the past couple of days, is a leader that has done a lot in this particular region of Asia Pacific, and I believe they can do more, and we have said that, and that will be just good for everyone. I think that one of the big things, the top priority, is really the commitment that has to change. And I just want to repeat what we wrote with Ben Murray, this was now 2010, so it's 5 years ago, in a Lancet series on tuberculosis, that I like to read this thing because I think it gives you a sense of what needs to be done to get commitment. So one needs to recognize that the efforts to control TB have a severe lack of political commitment at the country, at the international levels. Funding for TB is neglected sometimes, I would say not all the time, but is neglected because it is not a special program of the World Bank. It is not a named priority among any UN agency leader, does not have a special UN program like, say, UNAIDS. It is not in the UNICEF's portfolio, is not a special presidential initiative in the United States, as it has been for HIV/AIDS and malaria, and does not have strong support from the pharmaceutical industry compared with what's happening with other diseases, especially the non-communicable diseases. 95% of the investment by the big industry goes to non-communicable diseases. That's why we have the crisis of antimicrobial resistance in the world in general. It was even omitted from the formal title, as I explained, of the MDG 6, and only listed among the indicators. And yet, tuberculosis is the #1 killer, infectious killer in the world. And look at what has been said in the past 20 years. So it's nothing new here. So the World Bank World Development Report, which was an historical piece of work in terms of health economics, in a way, published in 1993, recognized chemotherapy for tuberculosis. At the time, there was not yet DOTS. It was chemotherapy for tuberculosis as one of the top, most cost-effective interventions in public health, together in a way with rehydration salts to prevent deaths from diarrhea in kids. And then that was repeated in the second edition of the same type of work in 2006. And look at what was defined more recently in 2013 by the Copenhagen Consensus and repeated by the special panel that Ban Ki-moon, the UN Secretary General, put together to look at the new Sustainable Development Goals. Tuberculosis case finding and treatment is, in their understanding, the most cost-effective, in a way, cost-beneficial, I should say, interventions above, of course, heart attacks, expanded immunization, malaria, and so on, giving you basically a return of some $30 for each $1 spent. So we have these very powerful arguments. The Economist has taken over. They were criticizing the SDGs because there are too many now. There are 17, too many targets, and they called the no-brainers. They said there are no-brainers here, so we should focus on the no-brainers and check what they are and see which one is the first in health. Okay, is this one. It is reducing tuberculosis. And that corresponds to roughly $40 gained out of $1 spent. And this was also reflected in this, again, the Copenhagen consensus here, that said by reducing TB deaths by 95% and incidence by 90%, which are the targets we have established, will basically guarantee a return of $43 per each dollar spent. And that is above any other health intervention that you can think of nowadays. So despite all of this, yet we complain, we would like to have much more available to fight tuberculosis, because we believe that this is a human killer and something that has really killed humanity from the very beginning of humanity should be dealt with in a much more serious way than it is dealt today. So with that, I thank you very much for listening. Thank you.
Thank you, Marian, for that very comprehensive overview. And I open the floor for any questions or comments. Raise your hand.
Hello, thank you for a very heartening talk in many ways. I'm a nurse and a midwife, and I work in infection prevention and control. And twice a year I go and work in the islands of Papua New Guinea. And what I see up there is nothing what's reflected here. It's growing exponentially up there, including multi-drug resistant TB in open bed wards, you know, that they cannot help but give to anyone else by being there. Every year I go back, like a medical ward has, with the 70 people in the ward, would have between 50 to 70% of those people with TB. And, you know, I used to go back and see one person, then 3 people, then 5 people with multi-drug resistance there. I see the number coming backwards and forwards to Australia with NGOs, with the mines that are increasing. They've got fabulous mining industry. The number coming backwards and forwards, as well as people coming down here. I see a huge risk with that. There's a wonderful missionary priest in one of the hospitals up there who happens to be an orthopaedic surgeon, who gets me to go through, and he said, Marty, even in the remotest villages, it's increasing exponentially. He's Polish, and he knows how to count. Many of the locals don't really understand counting and putting it together, but I'm extremely concerned with the worsening situation in Papua New Guinea. It takes me 3 hours to travel from Sydney to Port Moresby.
Well, yeah, absolutely. I mean, I know well the situation in Papua New Guinea. You're talking about a country, it's one of the few countries in the world that does not really have a national program, right? Okay, so most countries have a national program, structured and so on. Here you're dealing with a program that is very weak in the context of very weak health system, with services that are not accessible easily and so on. The incidence of tuberculosis in Papua New Guinea is going up at 3 to 4% per year. It's the highest rate in Asia. You know, MDR-TB in the Western province is in an outbreak type of situation. And that's why your government has placed there $16 million in very recent, in the last 1 year or so, to try to contain what is going on over there. But you are dealing with a country that is really among the weakest in the world in terms of the health system. Fortunately, not every country is in that situation, but countries like that are the ones that need focus, need attention by international agencies, cooperation agencies, and need collaboration, need everything possible because they are in a crisis situation. We have to face it. Yeah. 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 And this is where there is a need of extreme focus and help. And help. They are investing themselves. I was just talking yesterday actually to the Deputy Secretary of Health, who is here, and they are investing themselves now, they should be investing 8 million Australian dollars, with 16 coming from Australia, as I understand it. But they are a long way to go. They are now focusing on the Western provinces because of the outbreaks of MDR-TB. Yesterday they were saying we need to focus. They need to focus on the Port Moresby area, you know, the capital area, because you have 25% of the cases of Papua New Guinea that emerge out of Port Moresby. So they need at least to have programs that work in the western part because of MDR-TB and in Port Moresby because it's 1/4 of the cases. But that is not sufficient. They would have to have a national program like any other country. But, that is a very special situation. There are other countries in that kind of type of conditions. You think about the Middle East countries, affected by wars and so on. They are even in worse type of situations sometimes. You think about Afghanistan. Afghanistan today depends 99%, if not more, on international resources. Otherwise, they would not just have anything to face tuberculosis. So you have a situation like that. Well, that's why the international community is out there and should intervene. And our colleagues in the Western Pacific region have 2 staff there to help the national program to try to, what is called national program, to try to really become a national program. But it's a real concern. And there's no easy solution there except, when you have this bilateral cooperation, like in this case Australia, because it's nearby.
Thank you.
Thank you. Thank you for your inspirational talk and for coming to talk to students and colleagues at the University of Sydney. Could you please briefly outline the actions or strategies that should be taken to improve the quality of tuberculosis medications that are available patients in Asia, Southeast Asia in particular, and access to those drugs, because shortage of tuberculosis medication, second line, and first line drugs is not that common. We approach sometimes in Australia.
Yeah. Yeah, so that is another challenge. It was much worse, I can tell you that, 20 years ago, to the point that at the meeting that was I consider it at least an historical meeting. It was called the Ad Hoc Committee on the TB Epidemic, 1998, London. They decided that because of the frequent stockouts that were happening everywhere in the world at the time, right, stockouts of drugs, so patients would start 1 month, 2 months, and then they would have no drugs for another month or 2, and so on. There was a need of a creation of what was called the Global Drug Facility. That happened a couple of years later with Canadian money and then American money later on. The Global Drug Facility was hosted by WHO until last year and was hosted as part of the Stop TB Partnership that now has migrated out of WHO. They left WHO, but they are dealing with different issues nowadays than compared to 10 years ago. But that was really the response at the time to make sure that at least an international agency, so to speak, existed that would compensate for these frequent stockouts. Because of that, but also because, I would say even more, because of the global fund that was created now 12, 13 years ago, drug stockouts, to start with that and then we talk quality, but drug stockouts have been actually minimized. We used to receive, and in fact now it's 1 year or so that we don't receive complaints, but we used to have some chronic countries that would go into stockout regularly, like Uganda was a good example, because of their system of procurement, the general system that was not working. So you had this type of situation and they just needed correction. It's not just a matter of sending down the drugs in an emergency situation, which was always done by this global drug facility, but it was a matter of creating a drug procurement and supply system that was working. That has been one of the efforts in the past 15 years. And I think that nowadays the stockouts, at least at big level, are minimized. There was a big problem in India a couple of years ago, went all over the newspapers, especially pediatric formulations, if you remember then. It was all over in the newspapers because they did not have pediatric formulations in some parts of the country. So, there was international pressure. In the end, they seem now to have solved it, and I don't hear from India any longer. So, this stockout, I think, is relatively contained, but then you have countries where, as I say, if you don't have international input of money or drugs, you will always have the problem, like I was just mentioning Afghanistan. Quality is another issue, was studied well. There were papers that were testing the quality of the drugs, doing, whatever is necessary, pharmacokinetic studies and so on and so forth, to try to understand if the quality was good enough. There were reports in every country, not in every country is exaggeration, but in many countries, that the quality of the drugs was not at the standard that was required. And this you can correct only by having good, again, policies, is one of the things we are recommending in the strategy. Have a policy for the rational use of drugs and the quality of drugs. And that has to be a general health system policy that checks the quality of every single drug. There are pre-qualification mechanisms, there are many other mechanisms that can be put in place. It's an issue of, again, growing of the health system. I hate to constantly use this term, but if you are operating in a program that does not have a health system that works managerially, in terms, for instance, of procuring drugs, then you are stuck and you don't know what you're doing. So it's a general health system strengthening issue that has to be put in place, and it applies particularly now with this global crisis of antimicrobial resistance. One of the measures is indeed that of ensuring that the antibiotics that are used are of quality and that are used rationally. These are policies. Countries that are serious have the policy in place, have the agencies that check everything. Countries that are weak don't have that. So.
One more question. Final question.
About 5 years ago, there was a good report between WHO on the association between tuberculosis and
right.
And yet I see very little. You only mentioned it once in your talk that smoking.
Yeah.
And death. Any cause of death from smoking in South Africa is tuberculosis. There's nothing in the strategy here.
No,
rather than a decline.
Yeah.
Is there any comment about what the state of play with regard to TB and smoking?
Yeah, I did not mention it in specific term, but it's there in the comorbidities part. And we are using the framework you are referring to, which was published a bit more than 5 years, I think 7 or 8 years ago. The problem with the smokers, and there are, by the way, there are pilot studies that have been done. Okay, we work with our tobacco control colleagues, and this has been done in Nepal. It has been done in Brazil. There are attempts to link TB care with smoking cessation strategies. There are problems there if you think theoretically for a moment. We know that smoking is increasing the risk of tuberculosis by about 2 times, twice, as compared to the non-smoker. If you are infected with TB latently and you smoke, your risk is about twice that of a non-smoker. The problem is that either you do, the problem has to be solved in a way with tobacco control, because that's how you prevent TB. If you have cessation strategies, you have legislation that blocks smoking, like it has happened now in most of North America or Western Europe, then you have a chance of decreasing, smoking, and therefore preventing tuberculosis. Once you catch tuberculosis, and this is the issue, so what do we do in real terms at the primary care level? Once you have tuberculosis, it's too late. If you are a smoker, it's too late because you just had it. What you can do then is to, and that is what has been done in the pilot projects, is to link the care for the 6 months of the TB treatment with, say, smoking cessation and counseling and things like that, because that may have an impact on the mortality. There is also an impact on mortality. We know the smokers that keep smoking have a slightly increased risk of dying of TB during treatment, because of the failure of treatment, put it that way. And so what you can do with an intervention in real terms, where patients aggregate, i.e. in a TB clinic, you say, are you a smoker? Yes. So I give you cessation so that then you can decrease perhaps the risk of mortality. You won't prevent tuberculosis. Prevention of tuberculosis, you do it before they get TB. And that is where the tobacco control, call it that way, efforts have to be intensified. Is a determinant of tuberculosis smoking. But in practical terms, it's very difficult to do anything that is preventing tuberculosis. Nevertheless, I didn't mention it, but if I go back now, you will see it in comorbidities. That's what we are talking about. We are talking that, we are talking diabetes, the steroid use for chronic steroid use and so on, TNF inhibitors, etc., that are actually increasing the risk of tuberculosis among the latently infected people. But in practical terms, it becomes more difficult. Smokers do not aggregate, like HIV aggregate. They aggregate. People with HIV, they aggregate to go and get antiretrovirals, for instance. And so there you have a chance of combining interventions in primary care. When it comes to smoking, you catch the smoker, it's too late. He already has TB. So you see what I'm trying to say? It's tobacco control that will benefit tuberculosis. It's one of the determinants to be actually tackled. And that depends on Ministry of Health having policies for tobacco control.
Mary will be around afterwards if there are any additional questions. I would just ask you to join me in thanking him for having come all the way from Geneva.